So South Africa's President Cyril Ramaphosa announcing yesterday that the country has largely passed its peak of infections attributed to the third wave of COVID-19. President Ramaphosa said the easing of restrictions such as a lift on the ban on alcohol sales, easing of conditions at non-essential establishments like restaurants and inter-provincial travel for leisure was largely due to the drop in infections. Schools have fully reopened and social and religious gatherings are again allowed for maximum of 50 people indoors and 100 people outdoors. The nighttime curfew has been reduced to 10 p.m. from 10 p.m. to 4 a.m. Professor Salim Abdool Karim is the director of CAPRISA, a member of the African Task Force for Coronavirus. He's a public health specialist, world-renowned. He joins us now. A very good evening to you, Professor Karim, and thank you so much for speaking to us once again. And this might sound cynical, but I have to ask you this. Is South Africa ready for the latitude of alert level 3?
Very good evening, SABC, and good evening to all of the viewers. The answer is yes. I think we have a clearer understanding from our own experience and the studies that have been undertaken in several other countries that when the cases are rising, one needs to try and slow it down by decreasing the interactions. And because fundamentally, the number of people each person interacts with influences the rate of transmission. But as we hit the peak and the numbers start declining, then we've seen that we are in a position to ease those restrictions and allow more latitude or more leeway on the number of interactions that occur. But we have to be careful that we cannot simply do away with them, because if you do that, you run the risk of getting a second peak, because the restrictions have to be eased in a progressive way. We've now seen that from the experiences in Australia and in several other countries, that if you release too quickly, it has a way of springing back. So I think the way in which we're doing it right now is appropriate. We're easing certain restrictions, maintaining others, and we'll do that progressively, and that will take us back down to level 1 within probably the next month or so.
So what is the litmus test? We know that pressure on the healthcare system has been a big problem. Has that been significantly eased? And if we talk about a drop in COVID-19 cases, the test positivity rate, the hospitalizations, effectively, what does it mean if the deaths are still high or going up?
So we use several indicators, and clearly the number of cases is quite important. But the more useful measure, because we sometimes could get concerned about the scale of testing. If we have, for example, some of the unrest that we've had and the amount of testing goes down, we would expect the number of cases to go down too. So to avoid that problem, we prefer to look principally at the test positivity rate. And that test positivity rate from a high of well over 25% has now come down to below 25%. So what we will see now steadily is that percentage coming down. Now, as that percentage comes down, that gives us confidence that the epidemic is now slowing. We use another measure, which is an indirect calculation called R0, which is how many people does each infected person cause infection in. In other words, is the epidemic growing or is it declining? And basically, right now, our R0 is below 1. In other words, our epidemic is declining. So all of those are key indicators. Then we use admissions. Deaths are not really something we use because there's a long lag. The deaths rise about 3 weeks after the peak. So the deaths are not a good indicator. It's telling you about some things that have happened a long time ago. So basically, to summarize it, 3 key indicators: cases, test positivity rate, and admission rates.
Okay. Prof, I'd want to find out from you, just borrowing from international experiences, and especially those in developing countries, that I'd imagine that's where we'll be looking to for at least some effective lessons learned. it's been a huge stress test in terms of development. We're looking for our common survival. But there are those who say instead of opening up too early, why not wait, especially if there is the spectre of more waves, of more variants that may come to our shores. And if we open up too much, then there is the possibility of these infections growing because you keep on, closing and opening, closing and opening.
I know, and it gets tiresome, with all these changes all the time. But I think it's always, you want to find the right balance between your restrictions to slow the spread of the virus and to enable the systems and the healthcare to cope. But at the same time, you want to ensure that you're allowing enough economic activity. So finding that balance is always a bit of a challenge. But remember that balance will change. And the reason for that is very simple. The epidemic and the virus and the way it's spreading is continually changing. So you can't, in the face of an evolving and changing and rapidly changing epidemic, you can't maintain the same interventions for a long time because they become inappropriate and they will lose their impact. So we have to continually adjust it. I think doing so in 2 to 3 week intervals is reasonable. And I don't think there's much to be gained by trying to make very small tweaks. So I think the tweaks that we have made between level 4 and level 3 is about right because it still protects us from super spreading events, from mass gatherings. That's the main thing. But it allows businesses to operate, allows travel for leisure. It allows those things to go on because we can afford that at this time.
So, Prof, are we gleaning any more information about COVID-19 and how it is, developing as a disease, but just also what we're seeing in other countries? I'm looking at a report here that says that of 118 countries surveyed, there have been twice as many new cases of 50 countries. In 68 countries, more new cases. So only in 6 countries are there the same number of new cases, and in 47, fewer new cases. So it just seems to be a muddle of facts and figures, and it seems like we're learning as we're going along.
Yeah, it's quite incredible when you think about it, that when you look at South Africa, and that we had our first wave start in the Western Cape. Our second wave started in the Eastern Cape. Our third wave in Gauteng. So even in our own country, it comes at different points. The wave hits each of the provinces differently. And so when you look at the world as a whole, countries that are now going through a wave, barely 2 months ago, had low transmission. I mean, a classic example is, a country like Vietnam, or even, for that matter, Indonesia. Countries that really did not have significant transmission. In fact, Vietnam and South Korea were often lauded as, examples of how to really contain this virus. They're both dealing with waves right now. So we are learning that this is a virus that comes and goes in these waves. And those waves are impacted by vaccines. And this is quite an important finding now that we've got countries that have high levels of vaccination, like Israel, like the UK and the US. What we're seeing now in the UK and in Israel is that the Delta variant is still causing a wave of infections in those countries. But what we're seeing is that there are very few deaths that are occurring. So the vaccines are not necessarily doing that good a job in preventing infection, but they're doing a superb job in preventing severe disease and death. And so there's a real benefit to these vaccines, and we're going to do better with time. Vaccines are going to get better, we're going to see a situation where eventually we will have much better vaccines to even prevent mild infections.
Prof, can I just ask very quickly this question, and I'd like to hear it from your perspective of why there would be such a difference. So other countries that have less than half as many new cases, in Africa there is Sierra Leone, South Sudan, Eritrea, and Egypt, and Liberia. So I'm looking at, I know that a community healthcare system in Eritrea is much stronger even than in South Africa. But South Sudan, for instance, when you look at a public health system, it's virtually not there. But, the discrepancy is quite fascinating.
Yeah, so we've been meeting, I'm part of the African Coronavirus Task Force. And when we meet, we have representatives of various countries, and we share information about how we are dealing with the pandemic in each of these countries, and they share with us their information. Now, we do have some challenges in the amount of testing that's being done and in levels of reporting. But notwithstanding that, what we have seen in this last 2 months is that many countries in Africa, in the region of around 26 or so, 27, have had a third wave. And that third wave has been quite severe in most of those countries. In fact, most of those countries, the third wave was more severe than their first and second waves, just like South Africa. Our third wave was more severe, and the Delta variant was the dominant variant in those countries. Now, I can't explain why that's not occurring in every country. But I can tell you in the second wave, which was driven largely by the Beta variant, every country in Africa, with the exception of one country where we don't have data, right, Tanzania, in the other 54 states within the AU, all of them had a second wave. And all of them had a peak that was worse than the first wave. So I'm expecting that this third wave is going to get to all of these countries at some point, like the way the second wave did.
Thank you so much for your time and insights as always, Professor. And hopefully we'll get more time at some point to take a really in-depth look at how Africa is dealing with this and what we can learn in capacitating ourselves and, of course, helping the rest of the continent where we can. Professor Salim Abdool Karim is Director of CAPRISA and member of the African Task Force for Coronavirus. As he mentioned, testing, that's also a very important tool to help deal with future infections.